Good evening. Welcome to Ask Me Anything with Dr. Twyman. I'm a board-certified cardiologist, and my focus is on helping people avoid heart attacks and strokes. So if you want to prevent this stent, check on my social media where I talk about these type of things. And if you're looking to have us kind of work with you to figure out your risk factors, my practice is Apollo Cardiology in St. Louis, Missouri. So every Monday, 6 p.m. Central Time, we answer your questions. Monday morning, the Q&A box goes up in my stories. So if you have a question, drop it in there. I'll answer them as they're appropriate. And for people that are logging on, if they drop them in the comments, I'll answer those as well. So first question up tonight, how can you do for atherosclerosis naturally? Well, atherosclerosis is a common process. And if you figure out what's causing the damage to the endothelium and the endothelial calyx, you'll generally slow down that process. So you can look at things that affect nitric oxide. You can look at the oxidative stress and inflammatory markers. You can, of course, look at your lipoproteins. But lifestyle-wise, things that help is, managing your stress. The stress resilience is important. How will you sleep? That's when your mitochondria repair themselves. Your exercise, when you flow blood across your arteries, they release nitric oxide. And how you fuel the body. So don't eat too late. Maximize your protein for your muscle mass that you're trying to maintain. And eat seafood for brain food. So there are many things you can do naturally. I focus on an integrative approach. Use what works for the person. If that includes nutraceuticals, use nutraceuticals. If the person's high risk, consider pharmaceuticals as appropriate. Question, thoughts about strophanthin? Haven't seen much great data on it. I think that came from the book Cosmic Heart. Interesting, but haven't seen any good data that actually does much for the vascular system. Somebody says that their husband is type 1 diabetic, which would be a significant risk factor for vascular disease because the high insulin that's required to treat type 2 diabetics damages the endothelial glycocalyx. Oftentimes, patients who are diabetic and insulin resistant are going to have high LDL and low HDL. Triglycerides may or may not be high. What are the concerns? How the arteries are potentially becoming stiff, increased blood pressure, and do they have subclinical atherosclerosis? If they've not had a CT coronary calcium score test, that is something to consider. If they have hard calcified plaque in the artery, particularly if your score is over 300, that's equivalent of already having a heart attack and should consider doing something about it, including optimizing nitric oxide, keeping inflammation low, using nutraceuticals and pharmaceuticals as appropriate to optimize the lipoproteins. Generally, for a type 2 diabetic, you'd want to have an ApoB under 60 probably. How important is the microbiome to cardiovascular health? It's one of the levers. Your microbiome, digests the food for you. It's heavily under influence of your circadian biology. There's a very good textbook I recently acquired, Circadian Cardiology, with a focus on both prevention and intervention. So the gut microbiome has a chapter in there, but your gut microbiome is controlled in part by the light that enters your eyes and the light that hits your skin. Your microbiome is light dependent. The microbes respond to the wavelengths of light hitting your surfaces, in addition to the timing that the meals come in. So the gut microbiome can drive inflammation. A lot of your immune system is driven from your gut. So there definitely can be a component. If you have high inflammatory markers and don't have a great explanation why, often look at the gut. And then the last pre-submitted question was that the person says that their cardiologist wants to give me statins without a conversation. Well, that would be unfortunate because you have to understand what statins, the risk benefits are, and why you should consider using these type of agents. I tell patients they're tools, but you have to understand, is the tool being used for prevention or is it being used for treatment? If you've had a heart attack, stroke, stents, bypass, and you're in the secondary prevention category, statins are tools that significantly lower that risk. If you're a younger individual, particularly a woman, for primary prevention, statins may be somewhat overkill in that situation. So there always should be a conversation. Any people who are watching me that are my patients understand that I'm a little bit agnostic on which tools to utilize for people. I try to use pharmacogenomics when appropriate, but It's figuring out why the tool is going to be utilized. Because if you don't understand what the tool is doing, it's harder to have compliance. Be a little bit harder to understand, like if you're having a side effect, is a side effect worthwhile to kind of quote manage, or is it something that you should utilize a different tool? So would seek a second opinion if you're not getting the conversation that you want with your cardiologist, or ask them that you need more information before considering any lipid lowering therapy. So I think there was very few questions pre-submitted today, and I only see a few people on here. So if you want a kind of one-on-one interpretation of something that you guys are dealing with right now, just drop it in the comments and have to answer for you. Or if you're not wanting that question, don't often do it, but sometimes it's just go off the top of my head on any topic that you want to learn more about. So drop it in the comment and I'll try to answer that. See a few familiar faces in here. Hope you guys had better weather than we had in St. Louis today. We had a couple thunderstorms roll on through. All right, so we got a question here. So are PVCs, premature ventricular contractions during exercise, dangerous? Not necessarily. If you're having symptoms where you feel like you're going to pass out, then potentially they are going to be a problem for those individuals that are likely who have ischemia. So if you have lack of blood flow to one of your coronary arteries or in the microcirculation, the ischemia or lack of blood flow can drive the PVCs. The PVCs tend to get worse at increased heart rates in that instance. Patients may also have shortness of breath, chest pain during that time. The other concern is when you're stringing a run of the PVCs in a row, which is known as non-sustained ventricular tachycardia. Start approaching 30 seconds with that, you're likely to pass out because of the low blood pressure from the lack of perfusion of those kind of beats. They're not always dangerous, but you can look for a root cause. Again, maybe it's needs to work up for ischemia, but low electrolytes, including magnesium, potassium, very common to cause PVCs. Thyroid abnormalities can drive it. High oxidative stress and inflammation can also drive it. And thank you much for the feedback. We appreciate you guys as well. So I don't think I've been on any big name podcasts recently. There's a couple that are still in the pipeline that haven't been released. Once those get released, I'll let you guys know on that. Currently working on a at-home screening kit that will have a very novel way to draw your own blood at home, and then look at some tools that we can utilize to correlate the blood work, the imaging, the wearables, and give you kind of your heart attack risk at home. So working on that right now for you, so stay tuned. So for the question, any ideas on when the LPA-low drugs will be released? Great question. I was recently at the American College of Cardiology meeting in New Orleans. It was hoped that they would announce one of the drugs at the conference. It didn't happen, but one of the companies did finish their phase 3 trials in March of this year. The phase 3 trials were requested by the FDA. The drugs have so far in the trials been shown to be effective at lowering LPLA in the neighborhood of 85 to 98% in some of the trials. The phase 3 trials are set up to look at are there outcome data where patients will have less cardiac events. MACE is what the cardiologists call it, major adverse cardiovascular endpoints. These trials are done in secondary prevention for the most part, meaning people have already had heart attacks, strokes, coronary interventions, or carotid interventions. So for people who just have high lipoprotein A and never had a cardiac event, while the medicines may be available, they're not going to be covered by insurance in the kind of the starting point when they would get hit on the market. That being said, it's expected that one of the LPA drugs will be released within the next year. Likely 2 of them total will be released in the next 2, and there's 5 total in development. The greatest majority of them are some form of injection, but there is a oral version, I believe, in development as well. So hopefully within a year we'll be seeing it. They're about 2 years behind schedule on releasing the data, so it's going to be interesting when the trials finally get announced. What was the holdup and why it took longer? Potentially, it may have taken longer for people to have cardiac events in the trials than they were expecting. Question: what happens to the heart when we don't get enough sleep? The heart has to continuously beat 24 hours a day. It never gets to be fully at rest. Your body requires sleep to do autophagy, to kind of clear out the waste. So if you're not sleeping well enough, you often have higher oxidative stress and inflammation that can over time damage the circulation to the heart. If you're not sleeping well enough, there's a risk that you develop heart failure over time. So sleep is critically important. I often talk about 4 pillars of health: exercise, nutrition, stress management, and sleep. But sleep honestly is the most important. If you're not sleeping well, that should be your primary pillar that you work on for the next 90 days. Once you got your sleep dialed in, then that's when you can really start messing around with your nutrition strategies and your exercise. The person says that their 10-year-old son was diagnosed with tricuspid regurgitation. Should they be concerned? It depends on why they were diagnosed. If they were getting an echocardiogram for other reasons and they had seen tricuspid regurgitation, that's extremely common. Last time when I was still board certified in echo, it was somewhere in the neighborhood of 70% of people have tricuspid regurgitation. That's on the mild or trace side. So essentially it's normal when it's mild. If it's severe and is associated with right atrial enlargement or is associated with pulmonary hypertension where you have high blood pressures in the lungs, that is a more concerning finding. If the person has heart failure symptoms, if they have significant exercise intolerance, then more concern. If it's on the more trace to mild side, likely it's just a normal finding and shouldn't cause any problems long term. And while we're waiting for any other comments, questions to pop in, let me know in the comments. Also, if you guys are using any of the AI tools, what you're finding to be useful. I'm deep down the rabbit hole playing around with a lot of the tools right now. Personal favorites like Notebook LM from Google. That's the way that I'm really trying to learn things more efficiently. You can make your own custom notebooks and then use AI to summarize things, create infographics, create podcasts, create videos based off just the content, so there's no hallucination with it. And the other big one I'm playing around with is Perplexity Computer, creating different apps with it. I made a calculator that tells you, if you've had a clearly scan and have plaque in your arteries, you can plug in the calculator and it tells you what your risk of a heart attack or stroke is. So I'll be releasing that to the public in short order. Well, I'm not seeing any other questions at the moment. I appreciate your guys' time and attention as always. Every Monday, 6 p.m. Central, we'll be here answering your questions. Hope you guys have a great week, and we'll see you next time.